Thank you, Lenny. Thank you for inviting me to speak today, and congratulations on a successful and fun meeting. So with that, I'd like to talk about allogeneic stem cell transplant as a platform for post-transplant immunotherapy. The only disclosure I have is the same as Yossi. I'm a pediatric transplanter and still proud of it. So how does transplant cure acute leukemia? For many years, we believed that stem cell transplantation was part of dose intensification, that by using TBI and high-dose chemotherapy allowed us to avoid marrow aplasia and basically intensify treatment, and the purpose of giving a graft was to rescue the patient from aplasia. And then it became more obvious over the years that there was this graft versus leukemia phenomena. And it started out somewhat subtly. There were animal models in the 60s that showed a graft versus leukemia effect in mice. And then there were papers in the 70s, mostly single-center analyses from Seattle, showing that patients who had graft versus host disease had a less likelihood of recurring. And then over time, the relationship between GVH and GVL became more clear as the number of survivors increased, and data collection got better. And so many ways, the studies of GVL were in many ways the results of the IBMTR, the EBMT, and all the other registries and all the centers that sent in their data to these various registries. So this is a paper from the looking at transplant patients from the 70s and 80s, and what they showed was that graft versus host disease was associated with less relapse. And so here you can see patients with acute and chronic had the lowest probability of relapse, chronic alone, acute alone, no GVH, and T-cell depletion and twins had the highest probability of relapse. And so the concept of GVL at that time was so nebulous that we decided to ignore it and undergo technologies to prevent graft versus host disease by using T-cell depletion. And so in some ways, we showed we could prevent graft versus host disease, but in some ways, the T-cell depletion experience also was a way to validate the concept of graft versus leukemia. And over the years, there's been more data, and this is looking at ALL specifically, that there is a graft versus leukemia effect in ALL. This is from 527 patients with ALL in CR2 transplanted between 1982 and 92 with a MAT-CIB donor. And when they did their multivariate analysis, they found that GVH was the only significant factor predictive of relapse. And here you can see patients who had GVH had a lower probability of relapse than patients who did not have graft versus host disease. This is a more recent study, came out sometime early this year, from analysis of over 48,000 adult patients with a variety of leukemias, including about almost 7,000 patients with ALL, and they looked at the effect of graft versus host disease on relapse. And what they conclude was that the GVL effect was stronger in ALL and CML than it was in AML. And here you can see, for example, this is CML, which is we consider one of the prototype diseases for GVL sensitivity, and you can see here grade 2 GVH, grade 3, or grade 1, grade 2, grade 3, and grade 4. As you progressively had worsening GVH, the probability of relapse decreased. AML, it wasn't quite as strong, and here you can see ALL looked pretty similar to CLL, and when they looked at their hazard ratios, you can see grade 2 acute looked pretty similar to CML, Grade 3 looked pretty similar to CML, and AML looked a little different. So there are a number of factors that can contribute to a GVL effect. Many of them we don't really understand very well, but we believe that genetic disparity between the donor and recipient are important. Conditioning regimen is important, and as Dr. Rosenthal pointed out, that the more intensive conditioning regimen, the less you have to rely on GVL to cure the patient. And so they've actually shown that you do get more graft versus host disease with a myeloablative prep than seen with reduced intensity conditioning. And part of that is due to the tissue damage that's associated with TBI, and high-dose chemotherapy releases cytokines, which stimulates the allo response. One of the other issues is that the target antigens for GVL are poorly understood, as they are for graft versus host disease. We believe that minor histocompatibility antigens, which are polymorphic antigens that are really not associated with HLA, and those differences between donor and recipient may be very important in the pathogenesis of GVH and maybe GVL, and there may be overexpression or aberrant expression of polymorphic targets such as the WT1 antigen. And there are also multiple effector cells. Both CD8 and CD4 positive cells can mediate GVL in mice, and NK cells may mediate graft versus leukemia as well, and this has been best demonstrated in AML. So given the fact that we had shown that T-cell depletion increased the rate of relapse, and by this time we had become fairly convinced that there is a graft versus leukemia effect, along with the fact that at this time there were some exciting work from David Porter showing that you can give donor leukocytes to patients with CML who had relapsed and get them into remission. This was tried in a whole variety of diseases, including ALL and relapse. And this is a paper from Collins published in 2000, and it was the experience of 44 patients with ALL who relapsed after transplant and who received donor lymphocyte fusions. And the majority of these patients were in overt relapse, and unlike CML, the results were dismal. There were 7% alive at 3 years. I guess it's dismal for everybody except those patients who were alive at 3 years, but the results were very disappointing. So DLI for overt relapse kind of fell by the wayside, and people started to look at using DLI and trying to induce graft versus leukemia in patients who may have signs of early relapse. And the next few slides I'm going to discuss are the work from Peter Bader in Frankfurt, and they used chimerism as a surrogate marker for early relapse. And they hypothesized that the loss of chimerism was an indicator of a loss of either alloreactivity or early relapse. So they looked at chimerism, and again, that's the differences between the donor and recipient. But in 163 patients with ALL who underwent transplant, these were mostly kids. These are all kids. Their median age was around 9. 78 were related donors, 85 were unrelated, and there was one cord blood recipient. And multiple preparative therapies were used. And so what they did is they looked at chimerism weekly through day 100 and then once every month. And at that early report, they felt that if there was a 5% increase in host cells, they repeated the test the following week, and if that was confirmed, they rapidly tapered their immune suppression and or patients received donor lymphocytes. And then they found patients with increasing donor cells who had complete chimerism or had stable mixed chimerism. Those patients were just observed. So this is all of their patients, 163 patients. They had an overall survival of about 54%. When they looked at patients who had increasing mixed chimerism, and again, this is an increase in the amount of host cells seen over time, they had about a 23% survival. And patients who were complete chimeras or had stable but low-level mixed chimeras or had decreasing mixed chimerism, meaning you started out over time the increased percentage of donor cells continued to show, those patients had about a 66% response rate. And so what they did in many of these patients, they gave them donor lymphocytes. And so again, this is the patients who had increasing mixed chimerism. And when they treated those patients with DLI, they had about the survival was increased to 37%. And what's probably more revealing is that if they did nothing and just watched them, none of those patients survived. So there were a number of issues with DLI, particularly in this scenario, so that intervention with DLI for changes in chimerism requires frequent surveillance. And so they are now, Frankfurt is now doing weekly chimerism assays for the first week after transplant. Donor availability is a huge issue. We tried this once. We found a change in chimerism and then started to have to go through authorization to get the donor back. This is an unrelated donor. Authorization, it took 4 weeks before we finally got cells in and just in time to watch the patient have relapse. And so when I asked Peter Bader, how do you manage to do this? He said, in Germany, if you're told to donate blood, you donate blood. And so they just kind of made it work. So it's one of those little nuances that just isn't quite put into the papers. So, but probably more problematic for those who use DLI is that we cannot predict the ability for DLI to mediate GVL or GVH. The effect, and therefore the effect of cell dose is not defined. We have cell doses by which if you give too much, you get GVH but no GVL, but within that range of what we would consider therapeutic, we do not know the ideal cell dose. And the biggest issue is for ALL is that we need disease control for DLI to work. And I think that's the biggest problem why DLI works well for CML but not for ALL is because ALL is a fulminant disease and you need control until you can get the DLI to work. And finally, relapse disease progression still remains a problem, as does graft versus host disease. 10 to 30% of there's a 10 to 30% incidence of grades 3 and 4 GVH, and the worst of all is that you can have bad graft versus host disease and still relapse at the same time. And it's presumably that some of the targets may not be leukemia specific. So when I look at DLI, and particularly I compare them to the CAR cells are like the Ferrari. They're fast, they're sexy. There was a lot of creativity put into the design of these cells, and DLI is more like the Corvair. And I don't know if for those who are old enough to remember the Chevy Corvair, it was very popular during the 60s. General Motors decided to take out the sway bars to make them a little lighter and a little less expensive. And as a result, that led to Ralph Nader's rise to prominence, and he wrote this book, Unsafe at Any Speed, which was really his lambasting the Chevy Corvair. And it turns out that the Corvair, upon further review, was really no worse than other great cars during that time, like the Plymouth Fury, but the Corvair managed to take the heat for a lot of things at the time. But I like to think there are a lot of similarities between donor lymphocyte infusions and the Corvair. For one thing, the Corvair, it's very affordable. You can afford a Corvair. It's hard to, you can't not necessarily afford a Ferrari. And it's easily available. If you have access to the donor, you can get DLI. Like the Corvair, it's variable. It may have variable effectiveness, and so for people who love Corvairs and they are Corvair Club owners, it's a fantastic car, and for other people, it's a piece of junk. So the good news is that a DLI can be effective in controlling ALL in very early relapse in some patients. So the GVH-GVL effect can now is further extending over into the MRD data literature, and Mike Pulsipher's study from COG AST0431 is very illustrative of this phenomena. And in 0431, this was actually a randomized trial using a randomized trial between sirolimus plus tacrolimus and methotrexate versus tacrolimus and methotrexate alone. And the hypothesis was that there may be less GVH and less relapse with sirolimus, presumably by generating T regulatory cells. And so 144 patients with ALL were transplanted. They also did MRD as part of the study, and the study was eventually closed after meeting the stopping criteria for the primary goal of improving survival. Basically, sirolimus didn't make a difference in improving survival. But during that trial, they did do a 6-color flow. And what they showed was that the pre-transplant MRD of greater than 0.1% was associated with a higher probability of relapse. And patients who had minimal MRD positivity and MRD negative had about a 20 to 30% likelihood of relapse, and these were statistically significant. What he also showed nicely was that if you had graft versus host disease, you had less chance of relapse. This is probability of relapse for patients with grade 1 to 3 acute graft versus host disease, probability of relapse if you had no graft versus host disease. And if you had negative MRD and developed graft versus host disease, GVH was, your chances of relapse was still less. These are patients who had negative MRD and had GVH, negative MRD who had no graft versus host disease. And the thing that I was most excited about was that in the patients who are MRD positive and who developed graft versus host disease, the GVH was also helped lower the risk of relapse. And so again, these are MRD positive patients. If you had GVH, despite having MRD, your relapse rate was about 20-some%, and the relapse rate was probably close to 60% if you had positive MRD and never had graft versus host disease. So there were a number of lessons learned from 0431. One was that pre-transplant MRD levels were associated with a higher probability of relapse. 25% of patients with MRD less than 0.1% still relapsed, and I suspect, and I think as we've heard during this meeting, is that applying more sensitive techniques for analyzing MRD may be helpful to tease out that cohort of patients. Graft versus host disease can reduce the likelihood of relapse in MRD positive and MRD patients, and supports a GVL effect for ALL. And most patients relapse occur within the first 200 days after transplant, suggesting there's an opportunity to introduce some new therapy. So when I look at MRD, I look at it as the elephant in the room. We have this information that we obtain within a month after going to transplant, and we're all struggling with what do you do with the information after transplant. So I think in general, and I think this has kind of been a theme here, we need to develop strategies to reduce MRD prior to transplant. And I would argue the time to try to reduce MRD is early during their primary therapy. And my suggestion would be is to try to incorporate some of these new drugs way earlier on into the most high-risk patients. We need to try to look at, so when we do have a patient who has positive MRD, what we tend to do is use a myeloablative preparative therapy, and we would rapidly taper graft versus host disease if none occurs. And there are possible interventions for patients who are MRD positive who do not develop GVH, cellular therapy, and I like to say, if you can't afford a Ferrari, consider DLI for patients who don't get GVH. Donor availability, if you're using a related donor, ensures a unlimited supply of potential effector cells for DLI or potentially for genetic modification. I think the routine use of DLI will always be limited by a lack of understanding of the target antigens and the ability to predict GVL and GVHD. Patients with high pre-transplant MRD may warrant the risks of graft versus host disease and DLI, and then there's always the opportunity to incorporate some of the targeted therapies that we talked about into this window to try to prevent relapse. And so the future of transplant and the treatment in ALL, I think, will depend on a number of factors, including identifying the targets of GVH and GVL. And so, for example, we need to know what are the targets on leukemic cells that may predict graft versus leukemia. We want to look at and potentially look at ways to regulate the expression of these targets, and this may ultimately help identify which patients may benefit from GVH, GVL. We need better treatments for graft versus host disease that can reduce the short and long-term morbidities. And to this regard, we're doing studies looking at biomarkers for both acute and chronic graft versus host disease. That may give us a much better handle on when to initiate and potentially when to stop graft versus host disease or when to switch to other agents. And I think most exciting is that we are still trying to develop agents that can mimic graft versus leukemia, and if we can do so, then we may obviate the need for transplant. But at the same time, a lack of access to new agents, which will still, as long as there's a lack of access to new agents, we and our patients will still be driving Corvairs. And I think the one thing that I think we absolutely have to do is make sure that we can get these new and exciting agents to everybody so that we can apply them to our patients as soon as possible. Thank you.